we have seen something about QRS yesterday regarding its abnormality in amplitude and duration. In continuation with that, we are going to see another QRS complex abnormality in the form of fascicular blocks. It's a little more complex topic, so that's why I wanted to do it first when you're all fresh. So previously this fascicular blocks concept came only in 1980s, although the ECG is 100 years old. The concept of fascicular blocks came only in 1980s, as recent as that. So previously it was called as hemiblocks. People used to call it as a left anterior hemiblock and left posterior hemiblock, but the recent terminology is fascicular blocks, left anterior fascicular block or left posterior fascicular block. So once again, we concentrated on the chest leads to diagnose bundle branch blocks, isn't it? For as far as the fascicular blocks are concerned, you have to look at only the limb leads. You need not look at the chest leads at all, because it is going to primarily change your axis. So the primary, as I told you in the chapter on axis, why it is important is to diagnose fascicular blocks. So primarily the fascicular blocks are diagnosed by the change in the axis. That's why you have to look at only the limb leads. How many limb leads we have? Still 6? Yes, we have 6 limb leads. So we have to only look at the 6 limb leads to diagnose fascicular blocks. So once again, like any other chapter, we must know why we must learn about fascicular blocks. What is the purpose of knowing this abnormality? So primarily it indicates the disease of conduction system. As I told you, although we have 2 bundles, right bundles and left bundle, just like our coronary arteries, our conduction system behaves as a 3 fascicular system. The left bundle having 2 fascicles like left anterior fascicle, left posterior fascicle and right bundle branch. So although you have conduction, major 2 bundles are there, the conduction system behaves as a trifascicular system. That's why it's called trifascicular system. Left anterior fascicle, left posterior fascicle and also the right bundle branch. So whenever you have a fascicular block, it immediately indicates there is some abnormality in one part of the conduction system. So that's why it immediately indicates the conduction system disorder. So second very important aspect of diagnosing the fascicular block, to diagnose advanced conduction disturbances. For example, you have the fascicular block with a bundle branch block. It indicates a significant disease of the conduction system. Sometimes you have to even plan a permanent pacemaker implantation. We have the combination of fascicular blocks and bundle branch blocks. So it indicates the advanced conduction system disorder and plan aggressive management. And the most important aspect is many times the fascicular blocks may mimic an infarct, it can mask an infarct, or it can modify the ECG changes of myocardial infarction. Commonly, the left anterior fascicular block may mask inferior wall infarction. Left posterior fascicular block can mimic an inferior wall infarction. So that's why you have to learn about these fascicular blocks. See, we already told you about the conduction system. As you can see, this left anterior fascicle supplies the anterosuperior region of the left ventricle, and the left posterior fascicle supplies the infraposterior region of the left ventricle. So the whole left ventricle is depolarized by these 2 fascicles, whereas for the right bundle, because it's a thin ventricle, you have a single bundle branch which supplies and which depolarizes the right ventricle. So as I told you, the diagnosis of fascicular block primarily depends upon the axis, so you have to be very thorough in our axis chapter. Another important thing is, major portion of your ventricle is going to be depolarized by specialized conduction system in fascicular block. It is not as if one half of your ventricle is going to be depolarized by the specialized conduction system like bundle branch block. In the bundle branch block, one half of your ventricle was supplied by non-specialized conduction system, so that's why the QRS was so wide. Here only 1/4 of your ventricle is going to be supplied by non-specialized conduction system. 3/4 of your ventricle is going to be supplied by the specialized conduction system, so there will not be any significant widening. When an isolated fascicular block, in isolated fascicular block, there may not be significant widening, just small widening. It may be even up to 0.12, not more than, definitely not more than 0.12. A minimal widening of the QRS. So the 2 common causes of fascicular blocks are aging and coronary heart disease. These are the 2 important causes of fascicular blocks. Aging itself produces the fibrosis of the conduction system. Age-related fibrosis and degeneration of the conduction system is very important cause of this fascicular blocks. So this is the etiology of fascicular blocks is CAD and degeneration. So before we go into any abnormality, we always have the habit of knowing what is normal. Most often the normal is difficult than the abnormals. Many times we know abnormals, we do not know normals. So at first we must know what is normal. How normally these two fascicles are depolarizing the ventricle, left ventricle especially. As you can see, the left anterior fascicle is sweeping the anterosuperior region and the left posterior fascicle is sweeping the infraposterior region. So actually, when the impulse comes out of the main left bundle, the first vector which is traveling through the left anterior fascicle is going up and superior, and the first vector which is coming down through the left posterior fascicle is down and inferior and towards the right. So here it is inferior and to the right, here it is superior and to the left. They go like this. Then the main activation front of the left anterior fascicle. So the left anterior fascicle sweep like that, and main activation front of the left anterior fascicle is directed down and right, and main activation front of the left posterior fascicle is directed up and left. You understand this? So actually there are two vectors. The initial vector is going along the left anterior fascicle towards L1 and AVL. Then the main sweep of left anterior fascicle is coming down and inferior and towards the right. Left posterior fascicle is up and towards the left. So naturally, when they both combine together, normally our axis is around lead 2, which is 60. You understand this point? So they come like this. So the entire ventricle is depolarized from the sweeping left anterior fascicle and left posterior fascicle. So naturally they meet the center point of lead 2. Most often your normal axis is around L2. This is what normally happens. Normally happens. So in the left anterior, any fascicular block, the concept is any fascicular block, you have to demonstrate two vectors. One, the initial vector, second is the terminal vector. In fascicular blocks, these two vectors go in opposite directions. Initial vector will go in one direction, the terminal vector will go exactly the opposite direction. This is the concept of fascicular block. We will understand once we demonstrate what's happening left anterior fascicle and posterior fascicular blocks. So this is what I want you to remember. The initial activation front is going up and superior, and main activation front of the left anterior fascicle is coming down and right. Whereas left posterior fascicle, the initial activation front is coming down and right, and main activation front is going up and left. So they meet each other to have a normal axis around L2. So this is the normal activation of left ventricle by your fascicles. So let us imagine what's happening in our, so notice what is normally happening will be, so you have the anterior fascicle and posterior fascicle. So when the impulse comes from the main left bundle, it travels down like this. So actually the down and inferior left anterior fascicular activation, up and superior left ventricular activation meet together, and your axis is most often around lead 2. So this is what happens in the normal activation front of the fascicles. So let us imagine what's going to happen in left anterior fascicular block. Before that, there is some anatomical details. The most common of all three fascicular disease is the left anterior fascicular block. The commonest is left anterior fascicular block. Why? It is because of it is thin fascicle, and it has got a single blood supply by left anterior descending artery. And it is related to the left ventricular outflow tract, which has so much of pressure stress. The maximum stressful area in the heart is left ventricular outflow tract, where the left ventricle is pumping at a great force into the aorta. So it is related to the outflow tract, which involves a great stress. Because of these three reasons, the commonest of all the three fascicular block will be the left anterior fascicular block. And it is more prone for damage because of the three reasons. Most often, the left anterior fascicular block will be having a combination with a right bundle branch block. Why you can see in this, I will show you some other slide why it is very common, but most commonly it is combined with the right bundle branch block, because anatomically left anterior fascicle and the right bundle branch block are related to closely related to one another. That's why it is most often seen with right bundle branch block. So as I told you, it produces very small widening. When it is isolated, it cannot be more than 0.12 seconds, but when it is associated with the bundle branch block, you will have a significant widening. Please remember that. So whenever I told you the left anterior fascicular block most often will be associated with the right bundle branch block. So when the right bundle branch block is added on to left anterofascicular block, you will have a significant widening because right bundle branch block will produce significant widening. As an isolated lesion, the left anterofascicular block will produce only minimal widening. So let us see what will happen when there is a left anterior fascicular block. Now the left anterior fascicle is blocked here. So the initial activation front is not going through this. The initial activation front will be normally happening through the left posterior fascicle, which is down and right. Because of that, all your inferior leads, the three inferior leads L2, AVF and L3 will have an initial small positivity because this initial activation front is coming down and inferior, and this will be going away from your L1 and AVL. So L1 and AVL will have a small initial negativity. So this is normally happening the initial activation front of left posterior fascicle. Then the left posterior, by this time there is no activation front in the left anterior fascicle of the up and superior initial activation front is not there at all. So only the initial activation front is the intact left posterior fascicle, which results in initial small positivity and initial small negativity in high lateral leads and initial small positivity in inferior leads. Then this main activation front of the left posterior fascicle, which is directed superior and to the left, is no longer met by the corresponding down and inferior vector of the left anterior fascicle. So what happens is this vector goes on unopposed and goes on to the left anterior, the high lateral region to depolarize the region because that vector is not there. So this vector goes on unopposed, directed superior and to the left to depolarize the area which was supposed to be depolarized by the left anterior fascicle. So this vector becomes dominant. This terminal vector becomes dominant and this vector is directed up and superior and to the left. So because this vector goes on to the left, superior and to the left, the L1 and AVL will show the tall positivities. AVL will have the tallest positivity when compared to the L1, whereas L2, L3 and AVF inferior leads will have the terminal deep negativity because this vector, which is going up and superior, will be going away from your inferior leads. Do you understand? So this results in what axis deviation now? This results in what axis deviation? What I told you, what is the commonest cause of left axis deviation? Left anterofascicular block. So this results in left axis deviation. That's why whenever there is a left axis, you must immediately look for left anterofascicular block. How to look for left anterofascicular block? You have to demonstrate two vectors which are going in opposite directions. Isn't it? You see the two vectors. The initial vector is coming down and right. The terminal vector is going up and left. So this is the principle of fascicular block. Two vectors going in opposite directions. Then only you can diagnose a fascicular block. So the initial vector is down and right, resulting in an initial small positivity here, initial small negativity here. Then the left axis deviation produces the taller R wave in AVL when compared to the L1, resulting in a left axis deviation. So this results in a very small widening because up to this point it is supplied by the main conduction system, but only the small point is going to be supplied through the muscle. So that's why it produces very small widening when it is isolated. The important, very easy point to diagnose left anterofascicular block is, in left anterofascicular block, all your inferior looks exactly the similar. In no other disease condition, no other ECG finding will have this remarkable similarity of the three inferior leads. If you look at three inferior leads, they will exactly the similar. But no other condition, the L2 will be different, L3 will be different like that. But here in left anterofascicular block, all the three inferior leads will have classical small initial positivity with a deep negativity. They will look exactly the similar. It's a clue to diagnose a left anterofascicular block. Now let us see what's happening. Whatever I told you, this comes as a cartoon here. So my left anterior, this is what's happening normally. So the main activation front is going towards the L2 with a normal axis. Now we have block in left anterior fascicle now. So what will happen is the initial vector will come down like this and the terminal vector unopposed will go like this. So this results in, see what's happening, initial vector is coming down, which is an initial small positivity, and the late unopposed vector will be going towards the left, resulting in the left axis deviation, L1 AVL being the tallest, small initial negativity here, And you can see 3 inferior leads, small initial positivity and significant terminal negativity, and all the 3 leads looking exactly the similar. So this is what happens in left anterior fascicular block. It is the commonest cause of left axis deviation. Is that clear? I want to do it again. So just look at this this thing. So this is what happens normally when the left anterofascicle is blocked. The initial vector is coming down and right, and the terminal unopposed big vector is going up and left. This is what happens. So this produces initial small positivity, and this produces a terminal negativity in inferior leads. So that's what the left anterofascicular block is. So initial small positivity, large terminal negativity, and AVL will show initial small negativity and a tall positivity, left axis deviation, minimal QRS widening. You might, because there is some amount of QRS widening, there is some amount of depolarization delay. Whenever there is a depolarization delay, you will have secondary STT changes. So this is what the ECG of first. What is the axis here? What is the axis here? Axis is left axis. So once you diagnose left axis, immediately look at the inferior leads. What's happening in inferior leads? Initial small positivity with a terminal deep negativity. You see all the 3 inferior leads look exactly the similar. You see that L2 there, L3 there, and AVF there. Initial small positivity, deep negativity, small positivity, negativity. So initial vector is coming down and right, the terminal vector is going up and left, resulting in a left axis deviation. Very small QRS widening. So this is a classical ECG of left anterior fascicular block. So this is what the clue. The inferior leads looking exactly the similar will a clue to diagnose a left anterior fascicular block. So left posterior fascicular block is exactly the opposite. Whatever happened in inferior leads is going to happen in superior leads. Whatever happened in superior leads is going to happen in inferior leads. That's what, resulting in a right axis deviation here. Here it is going to right axis. Let us see what's happening to the left posterior fascicular block. The last fascicle to be affected is left posterior fascicular block. Left posterior fascicular block is the, as I told you, left anterior fascicular block is the first one to be affected. Whereas left posterior fascicular block is the last one to be affected. That's why you will hesitate to diagnose left posterior fascicular block from the ECG. But you can easily diagnose, just looking at an ECG, diagnose left anterior fascicular block by the ECG itself. But you must hesitate to diagnose a left posterior fascicular block because it is the last fascicle to be affected, because it is a thick fascicle. It has got dual blood supply of right coronary artery and left anterior descending artery. And it is related to the inflow tract, which is not used to have a very high pressure, because the blood is going to come from the left atrium to left ventricle at a very low pressure difference. So that's why it is not related to greater amount of stress when compared to the left ventricular outflow. So exactly the opposite of anterior fascicle. It's a thick bundle, dual blood supply, and it is related to a less stressful area in the heart. And it's less prone for disease. Whenever the left posterior fascicular block is there, most often the other 2 fascicles are also diseased, like your right bundle and the left anterior fascicle. So it is the last one affected. So by the time you diagnose left posterior fascicular block, most often you have the other 2 fascicles which are involved. So it also indicates an indirect evidence of disease of the other 2 bundles, because it is the least vulnerable to get affected. So let us see what's happening in left posterior fascicular block. It's the same diagram. So here my posterior fascicle is blocked. So my initial vector will be going through the intact left anterior fascicle up and left. So this will result in a small initial positivity of L1 and AVL, and initial small negativity, because this vector is going up and left away from my inferior lead. L2, L3, AVF will show a small initial negativity, and this will show initial small positivity. Then my main activation front of the left anterior fascicle is directed where? It is directed down and right. So no longer this down and right of my left anterior fascicular activation is met by the opposite up and left main activation front of the left posterior fascicle, because it is blocked. Because of that, this vector, which is directed down and right, goes unopposed towards the right side, resulting in a right axis deviation. Because this vector is coming towards the inferior leads, all your inferior leads will show the terminal positivity, but because it is a right axis deviation, L3 will show the tallest positivity. That's why it becomes a right axis deviation. So L3 will show the tallest positivity. So whatever has happened in superior leads has happened here, in inferior leads here. Whatever happened in inferior leads is happening the superior leads here in posterior fascicular block. So that's why when you have this 3 leads will showing a terminal positivity, L3 will show the tallest positivity resulting in a right axis deviation of, what is the number? 120. Good. Right axis deviation of deviation of L3. So once again you can see this cartoon. Now I have a block in my left posterior fascicle. So what will happen is my initial activation front will be going through the anterior fascicle, which will result in a small initial positivity L1 and AVL. Then main activation front of my left anterior fascicle will not be unopposed by the opposite vector here. So this main activation front will be traveling towards down onto the right, resulting in a right axis deviation. But terminal positivity in L2, L3 AVF, L3 will have the tallest positivity. So this is what will happen now. So the initial vector there and the terminal unopposed big vector coming towards L3, resulting in a right axis deviation. As I told you, whenever there is a right axis deviation, I told you, whenever there is a left axis deviation, you must think of left anterior fascicular block. You can immediately diagnose a left anterior fascicular block. But whenever there is a right axis deviation, what will you do? You look for right ventricular hypertrophy, not diagnose left posterior fascicular block. You must look for right ventricular hypertrophy. You must rule out the right ventricular hypertrophy clinically and otherwise. In spite of there is no right ventricular hypertrophy, still you have a right axis deviation with this classical initial vector going up and left and the terminal vector is coming down and right, then only you diagnose a left posterior fascicular block. So left posterior fascicular block is clinico-electrocardiographic diagnosis, whereas left anterior fascicular block is electrocardiographic diagnosis. You need not look at anything. Left axis deviation, the initial vector is down and right, terminal vector is up and left, you diagnose left anterior fascicular block, no problem. But when you have the right axis deviation, although you looks like left posterior fascicular block, you must go and look for right ventricular hypertrophy. Excluding right ventricular hypertrophy only, you must suppose to diagnose left posterior fascicular block. So opposite, you can also see initial positivity there in the superior leads and the initial negativity is there in inferior leads and the tallest terminal positivity in L3. Right axis deviation, minimal QRS widening, secondary STT changes. So you can look at this ECG here. What is axis? What is axis? What is axis number? 120. See which lead to confirm here? Lead 3 is axis. Which lead to look at confirm? AVL is negative. You can see that initial positivity in L1 and AVL, initial negativity in L2, L3 and AVF, and the terminal positivity in L2, L3 AVF, there is the R wave in the L3 is the tallest. So it's result in right axis. So what's the diagnosis here? What is the diagnosis here? I will diagnose left posterior fascicular block after excluding right ventricular hypertrophy is the answer. So when I ask you what is our diagnosis for this ECG, you must say, I will diagnose left posterior fascicular block after excluding right ventricular hypertrophy. Is there right ventricular hypertrophy in this ECG? No, because your R wave in V1 is, you see the V1 there. So immediately when you have a right axis, look at the V1 there. V1 you do not have RS ratio more than 1, R wave more than 7 and R in V1 and S in V5, V6 not more than 10.5, which is the criteria for diagnosing a right ventricular hypertrophy. It's not there. So most probably this is a left posterior fascicular block. Still you must have a clinical examination to rule out a right ventricular hypertrophy. Then only you diagnose a left posterior fascicular block. So this is a diagnosis of posterior fascicular block should be made after ruling out the right ventricular hypertrophy. So the last cause of right axis deviation, look for other cause of right axis deviation like RVH before diagnosing left posterior fascicular block, and it may indicate once again one of the common cause of left posterior fascicular block is coronary heart disease. So this is the concept of fascicular blocks. Left anterior fascicular block, left axis, the initial vector, terminal vector. Left posterior fascicular block, right axis, you have initial vector, terminal vector. Minimal QRS widening. The commonest cause of left axis is left anterior fascicular block, whereas the least common cause of right axis deviation is left posterior fascicular block. So now I am going to introduce the concept of monofascicular, bifascicular and trifascicular blocks. So now having diagnosed, we have some idea about the bundle branch block. We have some idea, I hope, some idea about the fascicular block. Now we have to combine both. We have to combine a bundle branch block with the fascicular block to diagnose advanced conduction system disorders. So we have to have the combination of two conduction system disorders. So the monofascicular block is the one where you have a block in only one fascicle. For example, you have an isolated right bundle branch block. You have an isolated left anterofascicular block, or you have an isolated left posterior block. It is called monofascicular block because single fascicle is diseased. So that's what the examples of a monofascicular block will be. Just any one of the fascicle can be blocked. It may be left posterior fascicular block, or it can be a right bundle branch block, or it can be a left anterofascicular block. Any one of the fascicle which is blocked is called monofascicular block. Then we come to the concept of bifascicular block. So as you can see the conduction system here, the anatomically your left anterofascicle and the right bundle branch is most often closely related together anatomically. That's why this combination is very common of right bundle branch block with left anterofascicular block. Another important reason is both these fascicles are supplied by the proximal left anterdescending artery. So whenever the left anterdescending artery is diseased, you will always have the right bundle branch block and the left anterofascicular block. Is one of the important left anterofascicular blocks, the one important ECG manifestation. When you see the serial ECGs in an anterval infarction, second day and third day, you will start developing, the patient will start developing a left axis and left anterofascicular block. Very common finding in an anterval infarction because it is supplied by the left anterdescending. So these two fascicles are anatomically related to one another and they are supplied by a same artery. That's why the combination is very common, right bundle branch block and left anterofascicular block. So whenever you have this is an example of a monofascicular block because it is what fascicular block here? LAFB or LPFB? LAFB. So you can see that remarkable similarity of inferior leads, left axis deviation, and see the QRS is not widened. When the QRS is not widened, you know there is no bundle branch block. When the QRS is not big, there is no big widening of QRS, you know there is no bundle branch block. That means it is only isolated left anterofascicular block, so it is a monofascicular block. So bifascicular blocks can be right bundle branch block and left anterofascicular block, which is the commonest. So now once you have a block in an RBB and a right bundle and also the left anterofascicular block, all your impulses from the sinus node after crossing the bundle of His has to go through only one fascicle. That is intact left posterior fascicle only. So you have only one fascicle which is working. So it is a more advanced conduction system disorder. So when the left posterior fascicular block is also blocked, the patient will go for complete heart block and Stokes atherometric. So none of the impulses from the sinus node will reach the ventricle because the impulses are going to be blocked at the bundle branches and the fascicular level. So no impulse is going to reach the ventricle. So ventricle will be governed either by idioventricular rhythm. If the idioventricular rhythm is not coming, you will go for a Stokes atherometric attacks and cardiac arrest. So that's why bifascicular block is more advanced conduction system disorder. A patient comes to you with a recurrent syncope. You take an ECG. Whenever there is a syncope, you always expect a bradycardia. So always when there is a bradycardia only, you think the syncope is cardiac. But here the rate may be normal, 70, 75. The patient may have a bifascicular block. He will have a RBB, you will have a left anterofascicular block. This fellow is going for recurrent syncope. You must imagine that intermittently his left posterior fascicular block is being blocked. So then we plan for a pacer at this stage itself. So that is the importance of diagnosing an advanced conduction system disorder. So not only look for a bradycardia, in any patient with a syncope, you must look for bundle branch block and fascicular blocks. So when there is fascicular block and bundle branch blocks, there may be the Stokes atherometric attacks is happening because one fascicle which is conducting may be getting blocked intermittently, which will be allowing the patient to going for recurrent syncopal attacks. So in this situation, you should not use drugs which will suppress the conduction system. For example, you diagnose a bifascicular block, you should not give the patient digoxin. You should not give the patient verapamil or diltiazem, which will further amiodarone, which will further depress your conduction system. So when you use drugs, when you have a bifascicular block, you know that only one fascicle is conducting. So I should not depress that conduction system by giving inappropriate drugs. So all these things are important to in the diagnosis of bifascicular block. So the bifascicular block is the block in the right bundle, most commonly a block in the left anterofascicle. So only the intact left posterior fascicle will be conducting the impulses. So when it is blocked, you will have the complete heart block. So look at this ECG here. What fascicular block is here? LAFB is there because it's a left axis deviation. Remarkable similarity, the initial positivity and deep negativity inferior leads. So as soon as you diagnose a fascicular block, immediately go to the V1 and see there. This is a dictum. Whenever you diagnose a fascicular block, go to V1 and see the V1 there. What is V1 there? Terminal, delayed, slurred, positivity over right sided leads, delayed, slurminal, negativity over left sided leads. So this is what? Right bundle branch block. So what is this? Right bundle branch block, left anterior fascicular block. It is a bifascicular block. That means in this ECG, what's happening? All the impulses are going through only one fascicle, which is posterior fascicle. So this fellow is coming with a recurrent syncopal attacks. You know, that fellow is getting intermittently, the posterior fascicle is getting blocked. So you have to plan a pacemaker implantation and so on. So that's why when you diagnose a fascicular block, if the QRS is much widened, so that is an important clue. Whereas I told you isolated fascicular block, you may not have a significant QRS widening. You can see here the QRS widening is almost 1.2 or 1.6 seconds, 0.16 seconds. So when there is a QRS widening there, immediately go to the V1 and see. Let us imagine that first you diagnose a bundle branch block because you are confident in bundle branch block. So when you are looking at the ECG, immediately you are diagnosing, looking at L1 itself. What L1? Terminal, slurred, negativity in L1. So what is it? So first you are diagnosing a bundle branch block. What you must do? Once you diagnose a bundle branch block, immediately go to the limb leads. What do you see in limb leads? Whether there is a fascicular block. So the dictum is, when you first diagnose a bundle branch block, look at the limb leads to see whether there is additional fascicular block. When you first diagnose a fascicular block, go to the chest leads and see whether there is additional bundle branch block. Then only you will diagnose this bifascicular blocks. Is that clear? So this is the dictum. Don't be happy because I am an ECG expert. I am able to diagnose a fascicular block. Don't be happy about that. Once you diagnose a fascicular block, you must see whether there is an additional. So another clue for fascicular block is QRS widening. When you have a fascicular block and the QRS is much widened, you must always look for additional bundle branch block. So now we have the concept of monofascicular block. We have the concept of bifascicular block. Now we are introducing the concept of trifascicular block. Here, when you have a trifascicular block, means the block is there in all the three fascicles. But when this trifascicular block is total, let us say all my three fascicles are not at all conducting, you will have a complete heart block, isn't it? That means none of your sinus impulses are going to come to the ventricle. Ventricles are going to be governed by its own rhythm of idioventricular rhythm. That means it is a complete heart block. That is the terminal stage, when all the three fascicles are totally blocked. But we are supposed to diagnose before this happens. Before the complete heart block happens, you must diagnose and see this fellow is likely to develop a complete heart block. I will put in a pacer to prevent a stroke fathom and sudden death in this patient. That is the concept of trifascicular block. So in a trifascicular block, what's happening is, in bifascicular block, I told you one fascicle is alone conducting. Let us imagine that fascicle is conducting abnormally, or that fascicle is conducting. It is conducting all right, but it is conducting slowly. It is partially diseased. It is not, when it's totally diseased, you will have complete heart block. When it is partially diseased, it will conduct very slowly, or it will conduct alternate sinus impulses. One impulse will go, one impulse get blocked, or two impulses may go, one impulse get blocked. So when the third fascicle is partially blocked, you will still have the normal rhythm, but there is a clue to say that the third fascicle is partially blocked. So you have to get the clue from the third fascicle. So when you diagnose a bifascicular block, you should not be happy again. You should not be happy again. You must see whether my third fascicle which is conducting normally or conducting partially. It is also diseased, is the third step in diagnosis of trifascicular block. All the three fascicles are blocked, possible intermittent blocks, and bifascicular block associated with the atrioventricular block. Let us imagine here, see this is what normally happens. I have already diagnosed a bifascicular block, RBB and left heart. Now my only fascicle which is conducting is left posterior fascicle. When it is partially blocked, when it is totally blocked, complete heart block. When it is partially blocked, the PR interval will be prolonged. You will have a RBB, you will have a LBB, LAFB, but must look for PR interval. Long PR interval means what? The long PR interval means my left anterior fascicle is conducting slowly. My left anterior fascicle is also diseased. So that means it is a trifascicular block. and you have to give the patient immediately a pacemaker at this point in time. Or you find an AV block. For example, RBB is there, LAFB is there. Intermittently, one P wave is blocked. Two P waves are getting conducted, one P wave is not followed by QRS complex. Three P waves are getting conducted, one P wave is not followed by complex. That, what does it mean? The left and posterior fascicular block is intermittently blocking one of the P waves. That means it is partially blocked. So either a prolonged PR interval or other evidence of atrioventricular block by intermittent blockade of the P waves, you must suspect the third posterior fascicle is partially blocked and the patient is likely to go in for a complete heart block and give a pacemaker at this point in time itself. So this is your trifascicular concept. So now this has got a QRS widening, isn't it? This ECG has got what? QRS widening. So once there is a QRS widening, what you must think? B1, what is it? What bundle branch block this is? Louder. Right bundle branch block. So what I told you, whenever you look at the right bundle branch block, what you must immediately see? See the limb leads. What's happening in limb leads? Left axis deviation, initial small positivity and terminal negativity. So what fascicular block is there? Left anterofascicular block is there. What is the third step? Look at the PR interval. Immediately look at the PR interval. See the PR interval there. More than 0.2. That means what? Your posterior fascicle is also conducting slowly. Then it is a classical trifascicular block. So don't be happy by diagnosing left anterofascicular block. Don't be happy by diagnosing a bifascicular block. Try to always look for additional disease in the third fascicle by looking at the prolonged PR interval or intermittent blockade of the P waves, which indicate that the third fascicle is also partially blocked, which may predispose the patient to a complete heart block. And given a pacer at this point in time, even the patient is asymptomatic, you must give a permanent pacer at this point in time, because to avoid a complete heart block in future. So this is a classical ECG of a trifascicular block. So this is the summary. Let us imagine, first I am diagnosing a fascicular block because of the abnormal axis deviation. My axis deviation is left, so I have looked for a left anterofascicular block. So I am diagnosing a fascicular block, either left anterofascicular block, by ruling out all the other causes, left posterior fascicular block. Once you diagnose that, I must look for additional QRS widening of right bundle branch block. So when the right bundle branch block is there, I am diagnosing a bifascicular block. Contrary, I am first diagnosing a QRS widening there. I am first diagnosing a right bundle branch block there. What I must see? I must go to the limb leads and see whether there is an abnormal axis deviation to produce a left anterofascicular block. So if I diagnose a left anterofascicular block with a right bundle branch block, I am in bifascicular block. Once I diagnose bifascicular block, I must look for additional AV conduction disturbances in the form of prolonged PR interval or intermittent blockade of the P wave, which may indicate a partial disease in the left posterior fascicle or the third fascicle, which put the patient on a trifascicular block, and the patient must go for permanent pacemaker implantation. So this is how not only diagnose a monofascicular block, from the monofascicular block you go on to diagnose advanced conduction system disorders and pick a patient or diagnose a patient much before he has major complication. That is the purpose of ECG learning. So after developing a Stokes Sadaman and complete heart block, everybody will diagnose and put in a pacemaker. But before that fellow develops that, you must identify and give in appropriate treatment. So this is your summary. Is that clear? So bundle branch block and fascicular block combination with additional fascicular block. Whenever there is one conduction system disorder, carefully look for the involvement of conduction system. This is what I told you yesterday. Obvious is obvious. Look for inobvious. Everybody will look like and diagnose a right bundle branch block. You should not be happy about diagnosing right bundle branch block. You must keep on seeing what other things are there, what other things are there. In ECG reading, the secret is try to see and try to diagnose what others will miss. You should not diagnose what others will diagnose. You must keep on seeing in this ECG what everybody will miss. You must start diagnosing that. Then only you become expert. So everybody will diagnose left anterofascicular block. They will miss left anterofascicular right bundle branch block. They will miss left anter. Even they diagnose a left anterofascicular block, they will miss a just prolonged PR interval, which may indicate a partial disease in the posterior fascicle. So this is the important lesson you must learn. Timely detection and interference can prevent complete heart block and Stokes-Adam attacks in future. So that finishes the first chapter.